Wonderful. I am so pleased to introduce our next presenters, the dynamic duo, Dr. Stewart Decker and Director Jennifer Little. They have an incredible story to share with excellent concrete steps that you all can take to become public health champions in your own communities. Dr. Decker is passionate about community health and collaborates with his local public health department in his role as a family medicine physician and medical director at the Sky Lakes Wellness Center in Klamath Falls. Ms. Little is the director of the Klamath County Public Health Department and has partnered with Dr. Decker to create a community of health in Southern Oregon. Their presentation, Public Health and the Individual Clinician, How Healthcare Providers Can Find Their Way into Community Health, will show us how it was achieved. I'd like to remind people to type your questions in the Q&A box and not in the chat box, and we will be able to get to those questions more easily after the presentation. So without further ado, Dr. Decker and Ms. Little.
Thank you so much for that kind introduction. We hope what we have to share with you today will inspire and encourage you.
So we are here to talk about public health and the individual clinician, kind of focusing on how providers can find their way into community health. When Joy first contacted us about giving this presentation, we were, of course, honored and delighted. And then she told us the lineup, and we were immediately hit with crushing imposter syndrome. After wallowing in said imposter syndrome for a couple of weeks, we realized that what we really have to offer is that we live in a small community in Southern Oregon where our public health professionals, like Jennifer, and our clinicians, like myself, know each other outside of the professional setting, and therefore we're really easily able to connect ourselves in the professional setting. So we have a lot of great experience with coordinating between public health efforts and individual clinicians, and that's what we're here to kind of share with you today. So we can progress to the next. Jennifer, I have no disclosures. Do you have any?
I don't have any.
Solid.
So what we're hoping that you learned today are how to understand public health frameworks and models, what public health professionals like myself need from clinicians like you and Stewart, and what the existing resources are to help clinicians get into this public health work. So just a quick glance, this is a picture of beautiful downtown Klamath Falls. For those of you who don't know, we are a rural community set in the high desert of Southern Oregon. Our county is the size of Connecticut, but home to only about 68,000 residents. Nearly 1 in 5 of our community members are living in poverty, and about half of our adult population lives with a chronic condition. HRSA designated us as a health professional shortage area, and for years, Klamath County ranked at the bottom of the Robert Wood Johnson County Health Rankings. This chronic lack of providers really necessitates the need for strong public health and health promotion programming to reserve physicians for the truly sick. Next slide. So this paints a little bit of a bleak picture, but again, we have it's a happy ending. And so after years of being at the bottom of those health rankings, Klamath decided to mobilize. So in 2012, leaders from our medical system, our CCO, public health, and our FQHC formed the Healthy Klamath Coalition. We conducted our first community health assessment and our first community health improvement plan, which really set the stage for health improvement projects through the years. Fast forward to 2019, and we have been recognized for our innovative and collaborative projects. And Klamath was one of 4 winners nationwide out of 190 applicants to win the Robert Wood Johnson Culture of Health Prize. And if you don't know about Robert Wood Johnson and this Culture of Health Prize, it's kind of like the Oscars of public health. So it was a tremendous honor to be recognized for that. Next slide.
So I'm not going to leave this slide up here for long, but this is the criteria that a community has to have in order to win that prize. There's that list of 6 things. You can obviously come back to this when you're reviewing our slide set, but the gist is that these 6 things really fold nicely into those public health frameworks that we're going to be teaching you in a minute. So here is our first learning point, the 2 different public health frameworks we're going to try to teach you guys today. The first is a socioeconomic model, and then the second is the health impact pyramid. That little subsection A, that is policy, systems, and environmental change. What you'll notice, it's kind of a buzzword currently in public health. So if you see PSE written everywhere, that's kind of the big focus for public health currently, is trying to make sure we're focusing on policy, systems, and environmental change, however we are approaching the projects we have. So next slide.
Okay, so Stewart mentioned the first model we'll talk about very quickly is the socioeconomic model. And there's a couple things that we'll highlight. Under here, you'll see yo-yos and WITs, and some people might think, what is that? Well, there are some individuals who feel like you're on your own, a yo-yo, versus some people who feel like we are in this together, the WITs. So it's the yo-yos versus the WITs. And what the socioecological model shows is it's kind of this nesting doll framework that shows how health behaviors and health outcomes are influenced. So at the very core of that, you have the individual, that's their knowledge, their attitudes, their skills, and it works out from there to their interpersonal, their families, friends, social networks. Organizations, maybe it's where they live, where they spend some time. Work out to the community and relationships between organizations. And then on that highest level is public policy at the national, state, local level. And what we've learned through the decades and the centuries is that those bigger bubbles have a larger influence on a larger swath of people, and they are simply more effective. And so we'll really be talking about how you as a physician can move up that ladder and work on more of that public level to get some of the work done. And those higher rungs really focus on that PSE, those policy, systems, and environmental changes. And we'll move along to the next slide, and we'll just give you a brief visualization of what some of this might look like. So on the left, you'll see this built environment that is not the most appealing. And someone who's in that yo-yo category, the you're on your own, might think, gosh, I keep telling this person to go out and exercise and they keep not doing it. Maybe they're just lazy or they just don't care. Not realizing that maybe this is where they're living, not the most appealing, maybe not the most safe. We're in this together, those WITs might consider, okay, if that's where they're living and they're not getting exercise, let's transform where they're living. So the picture on the right is the transformation of the same area, which now is this beautiful built environment that is much more appealing and safe and attractive to people to go out and exercise. And so if you're looking at that policy systems, environmental change, you're trying to focus on how do we get from point A, that not so great picture, to point B, the really attractive built environment. And that's what we'll talk to you about today, as how you as a clinician can help influence those changes. On this next slide, you'll see just another example. These are kind of the classics, exercise and nutrition. So this is a transformation that also happened in a corner store. On the left-hand side, if someone lives in a food desert and people are trying to tell them, you need to eat healthy, and this is all they have, chips and soda, that's going to be a little bit more difficult. It's not simply a lack of willpower, right? But you can see that transformation maybe through a healthy corner store initiative, where now that same space has healthy options, fruits, vegetables, looks like some juices and waters in there.
So in this next slide, you can see that socioeconomic model with the bubbles going up, and we'll focus on the bottom. The individual is what the individual knows and believes. So in this example, we'll go through something near and dear to Oregonians' hearts, vaccines. So what the individual knows and believes about vaccines, the side effects, the benefits. So we've all been in those situations in the office working with someone who believes a certain thing about a vaccine, and we're trying to convince them of a different thing. The next step up is where we start encouraging people to think about the interpersonal level. So when maybe what their friends have done, what their friends know, their friends' experiences, their family. That's a location where we can have an influence. Organizational locations, that's churches, churches and schools hosting clinics. A really big deal here is electronic health records at your health system. So just trying to maximize the systems to really highlight if someone needs a vaccine and when. In the community, you have examples of health fairs connecting public health and school boards, PTOs. And then the last thing is policy level. So removing non-medical exemption, changing school recommendations, requiring education in health classes. Those are some examples of locations where we can influence finally that bottom individual's decision, their health behaviors. So on the next slide, we'll move on to the next public health framework. That's the health impact pyramid model. I love this one because that little top triangle where clinicians traditionally have an impact just looks a little more friendly, looks a little bigger. There's counseling education where we're talking to people, teaching them things. There's our clinical interventions, and then vaccines and colonoscopies are long-lasting protective interventions. I think we are all here today because we're a little bit on that yo-yo side, or sorry, that WIT side of that spectrum. And we all kind of want to get to that point where we're really impacting the bottom of the pyramid. So the next slide will just highlight changing the context to make individuals' default decisions healthy, and then socioeconomic factors. So the big question is, how do I get from the top of the pyramid to impacting the bottom of the pyramid? So in the next slide, you'll see one really cool example of a resource. This is the High 5 Impact, or the Health Impact in 5 Years, produced by the CDC. So the reason I love that health impact pyramid is because the CDC uses it. The criteria for being included in this website or this endeavor by the CDC is that these interventions have to have positive health impact, results within 5 years, and then cost effectiveness or cost savings over the lifetime of the population or earlier. So if you're someone, and we'll get to where you can be in this spectrum later, but if you're someone who really likes to or wants to get into the socioeconomic determinants of health, but you don't really know what to focus on, you can maybe take a tour over to the CDC and look at the listed interventions that have proven impact. And some of these, one thing I really like to point out on this slide is that some of these are obvious. There is access to clean syringes or tobacco control interventions. Those seem like obvious wins. What I love about this is there's some really not obvious ones. So home improvement loans and grants, earned income tax credits. These are things that have proven effectiveness for positive health impacts and cost effectiveness over the 5 years. So I find that just really impressive. It really drives home the point to me that health is everything and everything is health, which just means that if you are someone who has an interest in biking or an interest in electric cars, you can use that interest to really push for public health interventions within your field of interest. So let's pop over to the next slide. We have now completed Learning Objective 1. We've taught you some public health frameworks. We're going to transition to objective number 2. So what public health needs from clinicians. We'll get to this slide earlier, but a little background is public health has gone through a number of transitions. So in the 19th and 20th centuries, we're really looking at public health 1.0. So this is a period of great improvements. We're talking sanitation, transportation, housing, clean food and water, vaccinations, antibiotics, just huge impacts. And at those stages, we needed clinicians to apply those things. We needed clinicians to give vaccines, give antibiotics. Public Health 2.0, which is the next step, that's the mid to late 20th century. That's when public health started getting organized around specific problems, specific disease-oriented processes. So creating specific programs to address emerging threats and rising burdens of disease like HIV. So you can imagine lots of specific programs for specific diseases. Now we're transitioning to Public Health 3.0. And in Oregon specifically, we call this public health modernization, which Jennifer will talk about in a second. But what that looks like is trying to move public health upstream to not need specific programs for diseases that already exist, but try to work to prevent those illnesses from becoming problems in the first place.
Right. So as Stewart mentioned, public health modernization is a thing in Oregon. So with the passage of House Bill 3100 back in 2015, and then later the House Bill 2310 in 2017, public health modernization is now written into law, and it guides our funding, it guides how we do our programming, ensuring that we have strong foundational programs and capabilities. So if you look on this slide, this is a diagram showing what public health modernization looks like in Oregon. So you'll see across the top, we've got those foundational programs: communicable disease, prevention and health promotion, environmental health, and access to clinical preventative services. So obviously there's a few areas where clinicians really fit nicely into these, and some may be a little more nebulous, but again, we're going to talk to you about how you can start dabbling in some of those more non-traditional programs. And then on the bottom here, you'll see we've got the foundational capabilities. So these are what really support those programs. It drives our work forward. These are the things that we are held to and that we need to do in order to meet the needs of our community. And so the Coalition of Local Health Officials and Oregon Health Authority, we had this framework and we had to figure out, well, where do we start? And thank goodness somebody had some foresight and we started with communicable disease. And so regions and communities partnered and we conducted health assessments, and we were able to decide on what our communicable disease work was going to look like based on the needs of our community. And it was this really beautiful relationship that Stewart's going to talk about, of how public health and primary care really married for some pretty cool outcomes.
So you might be thinking, you know what, this sounds a little familiar. We're going to start an analogy here that we'll come back to, but the idea is that public health as a whole, within Oregon specifically, is at this stage where it's trying to start relationships. It's trying to find the right match for this area, right match for this one. It's going through trying to find programs and individuals who it wants to partner with. Sounds a lot like it is on the single and ready to mingle spectrum of relationships, which to me, it means that we should probably have something like public health Tinder. We should have a way in which interested parties can meet other interested parties. So one of the big questions people ask themselves is, how come I am not, how can I get into public health? How can I create a relationship with a public health program? And one of the first answers is you have to be available. You have to update your profile. You have to make public health know, or let public health know that you are interested in having a relationship with it. So we'll come back to that analogy in a little bit, but we're hopefully looking for a public health Tinder that can connect all of our interested parties together. So we'll go to the next slide.
So like we said, public health modernization, we started out with communicable disease. Here in Klamath County, we partnered with Jackson County, and we were really looking for how we can move forward. Part of our project was HPV vaccinations. So I'll let Stewart talk about that process.
Yeah, so the very first thing we did, again, the background is Jennifer and I, and the public health department in general, and I knew each other from my time in Klamath Falls and how small it is. So when the public health department needed a medical champion, someone to really drive home the connection between public health and individual physicians or individual clinicians regarding HPV vaccination, they kind of approached me. So that's always going to be stage one, is the parties need to know that they're interested in each other. I was recruited as the medical champion for HPV vaccinations. And what that looked like for me was partnering with a public health organization, a public health department, to create and edit a train the trainer presentation for how to talk about HPV vaccinations in clinic. And we trained providers, yes, but we also trained MAs and rooming staff and front desk staff and clinic administrators to try to maximize all of the ways we could come at this problem. So rooming staff were addressing the topic with patients as they were rooming them. We were changing the health system in that we took a look at our EHR and we created new templates for well-person visits and new structures for warning or highlighting a patient's vaccine lack or need for vaccination before the provider actually went into the room to see them. So this was an example of a really nicely realized partnership. A connection was made, and then the parties involved went back and forth with new ideas on how to further the partnership, going from training trainers, going to every clinic in town to give this presentation, to then changing the health system and the electronic health record itself. So we'll give a couple other examples of how public health and individual clinicians have worked together in Klamath Falls and look forward to working together in Klamath Falls in the next couple slides.
Mm-hmm. So we promise you this is our only COVID mention in this presentation, but with this COVID response happening very quickly, it really did highlight the need for this intersection between primary and public health. And hopefully this looked very similar in your communities too, but some of the things that public health really relied on physicians for were things like having standing orders. For example, at a long-term care facility, they needed standing orders for their staff and their residents to be tested. Or for when we had mobile testing sites out in our outlying, very rural communities, we needed standing orders for those. And looking forward, when we do have a vaccine, we're going to need standing orders for those. And so that's a really great way where providers can use their expertise and their degrees and certifications to help further these public health responses. In addition, we relied heavily on our medical community to help with our public messaging. When providers say something, it carries a certain amount of weight and respect because just historically, doctors are well-respected members of society. And so we relied heavily on them to help carry our message. We also, of course, relied on our providers to give those patient notifications. Before we started our case investigations, they helped us with communicating about what to expect and how to take care of yourself while you're in quarantine or isolation. We also partnered with our primary care providers for turning their clinics into testing stations or to help with those mobile testing sites. And in addition, we found that there was a lot of individuals who tested positive for COVID and didn't have a provider. And so we relied on our providers to open up their doors and accept new patients on maybe a faster pace than they would have otherwise. And on this next slide, you'll see, so I said getting away from COVID, that was our only mention, I promise. So another area that is a public health crisis that we absolutely need to partner with physicians and other community-based organizations are things like substance use disorders. And so, for example, particularly in rural communities, we don't have many Suboxone providers, and we need more of them, and more of them to feel comfortable doing this kind of work. And so I'll turn it over to Stewart to talk about his experience with some of this work.
Yeah, so I think that this is a great example for the second time this topic is going to come up, which is a medical champion. So some things that I learned from Jennifer during this presentation is that for inpatient treatment for substance use disorders, those locations need an H&P done within 24 hours of intake. I mean, I didn't actually know that, and that's been law for a year. Now, I think that this is a great example of when a medical champion is a perfect solution. So all a health system needs is one provider to know that little fact and then disseminate it out to the rest of the providers. If nobody knows it, or if nobody is designated or has decided to become that medical champion, it becomes a lot harder to know those little factoids and then distribute that information. This is, like I said, this will come up again, but the idea is that a medical champion is one of the best ways to partner with public health departments. An example of that is I'm starting to become a Suboxone provider, and it's hard because I am becoming the medical champion for that within like my little clinic area. And I'm reaching out to find out who has done it before in my area and how they set up their clinic and how they set up their system. But my experience really does, like, I have reflected time and time again about how much easier it would be if someone who already knows what they're doing can teach me how to set up my clinic. So I'm seeking a medical champion within my community who can show me how to do this. Otherwise, I'll become it myself. But just really highlights the need for that person to be the intersection between these two groupings of health. So in the next slide, we can see just another example. Jennifer mentioned mobile clinics. In Klamath Falls, we have really rural outlying areas, and we're developing processes with mobile clinics. So this is another way that providers can become involved with public health, is writing standing orders or helping promote or helping fundraise or helping write grants for mobile clinics. In the next slide, you'll see another way that clinicians can intersect with public health, which is within advocacy. So the picture on the slide is our White Coats for Black Lives protest or gathering in Klamath Falls. We spent about an hour over lunch at a corner in downtown having lots of really fruitful conversations. Clearly everyone's wearing masks, which is a great example setting in two ways. Other things you can do as an advocate is writing letters to the editor, offering testimony for specific bills that may be going through the legislative session, calling your senator, calling your elected representatives. So in the next slide, I'm going to summarize this a little bit for you. I just want to remind you that when you are trying to connect with public health as an individual clinician, the very first step is making your interests known. And Jennifer will talk about how important this is, how desirous just sitting with a person and having meetings or getting coffee can be. But the first step is always make your interest known. If you are the most interested person in the built environment, but the people doing the built environment in your community don't know it, you're never going to have a cool project fall in your lap. So what I like to summarize, the way I think about this is that public health needs individual clinicians to be one of two things. You either get to be a medical champion. This can be for any current or future project. This includes the pandemic. This includes specific projects like a needle exchange van or bike trails in your community. This is true for specific populations, the Native population, other disadvantaged populations, or it could be connections to other organizations like community-based organizations that aren't necessarily the public health department proper, but are doing a lot of really good work in the community and could use a little help from a clinician. So option one, medical champion, really big driver for something connecting. Option number two is advocates. So public health needs advocates. This can be community-wide versus organizational. A great example of this on a statewide field currently is the tobacco tax that's going to be coming up on our current election cycle. So physicians advocating for something that is clearly tied to health is a really impactful and important voice. So if you are a clinician and you are interested in being an advocate, things you can do, like we said, you can write letters, you can write editorials, you can sign on to those letters or editorials, you can make calls, you can record messages, all sorts of options for advocating. And the real key for advocating is if you don't know what to say and when to say it, you ask someone like Jennifer, or you say, hey, Jennifer, I am interested in being an advocate for you. Please tag me when you need something.
And believe me, we will. And so like Stewart was saying, if you were interested in a letter to the editor, but maybe you don't have time or you don't know what to say, we are happy to write those for you. And then we'll run it by you, make sure you're happy with what we're saying. You can edit it, and then we'll even submit it for you. We will make this as easy as possible. And there could be advocacy that happens just within your own organization. For example, Stewart was talking about getting Suboxone providers up and ready to go. Or maybe you want your hospital to become Safe Sleep certified, and that has to do with passing internal policies and training your internal staff and having a champion to say, we want to promote safe sleep amongst our new families, and here's how we're going to do it. Another really great way that you can indirectly advocate is to recruit your patients who have this lived experience to offer their voices on committees and boards. For example, every CCO in the state has a community advisory council, and by mandate, those community advisory councils must have 51% member representation, meaning those people have to be on the Oregon Health Plan through their CCO on that community advisory council. And something that's been really successful for us here in Klamath has been physicians having a conversation with their patients saying, hey, you would be a really great person to represent people of your population, maybe in your neighborhood, on this community advisory council. And that means a lot because, again, physicians and clinicians are respected members of the community. And when they say, I think you'd be good, you should represent on this board, it means a lot. And so you can advocate for others to also be advocates, which is really helpful. So on the next slide, we'll have Stewart talk to you about some other ideas. Like he was talking about, it doesn't have to be just public health. There's tons of community-based organizations that have public health influence that you can tap into.
Perfect. So again, it's a lot of text on this slide, so we don't need to read through each one, but this is more of a reference slide for you. If you are someone who is really on that WITS spectrum, we're in this together and you're struggling to find a way to make that difference on those bottom pillars of that health impact pyramid, here's some great ideas for how to get connected with either organizations doing things or just some ideas for what you might find yourself passionate about. So you can talk to the OSU Extension Service, which does an incredible amount of work with food, nutrition, and schools. You can call DHS. You can visit your senior center. Jennifer actually sits on our senior center board, which is amazing. One of my favorite things that Jennifer also taught me how to do is subscribe to your local newspaper. That way every Sunday you can sit and read and find out what cool things are happening in your community, and it might just spark a little interest for you. Some article about a program that's happening down the street from you that you didn't know about, but now you do and kind of want to help with. My favorite one is J, which is contact your director of public health. Jennifer can attest to this, but if a clinician calls her up and says, hey, I'm interested in helping with public health, but don't know how to do it, could we have a meeting in which to talk about my interests and what you need? Jennifer, how do you feel about that sort of call?
I love taking meetings, especially coffee meetings.
There we go. So you've heard it from the source. On our next slide, you'll have some other ideas for what you can specifically do for people or do for organizations. The gist is this slide is showing that there's a number of ways that you can interact with organizations. So you can sit on an organization's board, you can join a committee, you can write letters to the editor, write op-eds. These are things that we've talked about before. Again, if you don't know what to do, but are just curious or interested in doing something, this is what Jennifer means by it's okay to be a tool. Your basically capital within the community is your trustworthiness as a clinician. The public loves to hear things from people who they trust, who they believe have their best interests at heart, and people in the medical field just have a really beautiful trust capital. And public health departments can really use that trust capital. So when a letter is written by a clinician, it means a lot more than by Stewart Decker, the individual. So when she says we can use you as a tool, that means that they always have ways to use a clinician, to whether it's just signing on to a grant application or signing your name at the bottom of a letter that you agree with but didn't have to write, all the way to sitting on a board or teaching community classes. Usually organizations like the public health department or CBOs will have ideas for how to use you, the tool, the clinician, to further some of those public health ideas. So in our next slide, we're going to progress to learning point number 3, teaching you about some existing resources and roadmaps. Jennifer, your internet back on?
I think so. Can you hear me?
Yeah.
Okay, great. So you'll see, and I mentioned this earlier in this presentation, but we have community health assessments and community health improvement plans. And so every county that is in Oregon has one of these, I guarantee it. And you'll see here at the bottom that if you have a nonprofit hospital, they have to have a community health assessment every 3 years, dictated by the IRS. Every coordinated care organization must have a community health assessment and community health improvement plan done every 5 years. Local public health authorities, same thing, every 5 years. Federally qualified health centers, every 3 years. Hopefully they aren't all doing those separately. They're called community health assessments and community health improvement plans because they should all be combined. And I think that's happening more and more. But this is an excellent way to figure out what is happening in your community and what has been prioritized by people in the community. This wasn't just one person sitting in an office writing up these plans. These are meant to be collaborative projects. And so if you go to the next slide, this is just one really quick clip from Klamath's Community Health Improvement Plan. This is one of our priority areas that the community said, this is really important to us. We came up with our objectives, our strategies, we have baseline data, we figured out what a reasonable target would be. And so reading over your community's CHIP can help you understand what are some of the priorities, what's the work happening. But in addition, hopefully, and like ours does, it's not on this page, but it also says what other organizations are helping with that work. So if maybe you don't want to get involved with the public health department, but you want to get involved with one of the CBOs that's also helping with this work.
Maybe that community-based organization can get you connected as well. We do have, there's an ArcGIS web page that hosts all of the CHIPs for all of the counties in Oregon. We can have that in some notes for you that you can access. It's just a really long URL, so not a great thing to put on a slide for you to frantically copy down. If you go to the next slide, this is a second resource that we have available to us in Klamath Falls. It's called the Healthy Klamath website. So it is beautiful. I love this website. You can see on the right just a screenshot of one of the opening pages. In that screenshot, I have clicked a button that says join us, get connected with a work group. So you can enter your email address, your name, and then you can see on the left, you can just click on which work groups you're interested in. And my experience with this is I just wanted to test it out. I logged on to it. I'm already on a lot of these work groups, but I clicked the buttons and I pressed enter, and 30 minutes later, I got an email from Kendra Santiago, who is the woman who is monitoring this site, saying, hey, Stewart, you know you're already logged in for most of these, but we're happy to have you. So there, at least in Klamath, this is a really well-utilized, well-resourced resource for you to just get immediately plugged into things that are going on in your community with community members. If you go to the next slide, we have an example of a similar website in Clackamas County. So we perused around Oregon. We were looking for other organizations that had similar websites, and we found at least one, Healthy Clackamas. They also had a Get Involved button. You can see that right there on the right. So perhaps your community has a website like this, or maybe they don't yet have a website like this, and they should. Maybe that's a point where very globally, you can poke your community in the right direction. If you go to the next slide, we have kind of a summary for that last section. This is how to create connections with organizations. So we talked about how to create connections as individuals, how to create connections as an organization. In this one, I'm talking directly to the OMA, OAFP, other member organizations. I just want to point out that you have a ton of members, and a lot of your members are very interested in public health and interacting with public health. Perhaps you could be a touch point for connecting with public health agencies, connecting physicians, connecting clinicians, connecting individuals with community-based organizations. Maybe some interventions that could really highlight that maximization or maximize that interaction is inviting public health representatives to your meetings. Maybe you could be a driving force behind creating a Healthy Oregon website instead of just a Healthy Klamath website. So the question, the ask is, can you be our public health Tinder? So we'll progress to the next slide. I'm going to summarize. Jennifer, welcome back.
I'm so
sorry to have you missed. We breezed beautifully through. We're just at the summary slides now. If you are, so the summary, if you are an individual and you're looking to get into public health, I think that you are in one of two positions. You either know exactly what you want to do. You already know what you're interested in. You know that you love the built environment. You know that you are really passionate about tobacco. Whatever it happens to be, your first step is to find the people doing those things, and you can use the Healthy Your Community website. You can use the CHIP, like Jennifer mentioned. You can use just the internet. You can use your Sunday paper. You can use these resources we talked about, and then schedule a meeting with them. Call somebody up and say, hey, I'm interested in helping. would you like to just take down my name and number, and then you can call me if you need an editorial written, or I would like to do something more. Can we talk about what are all the things I can do for you or with you? Option 2 is you're someone who wants to do public health work, but you have no idea what you want to do. You're just kind of lost in the overwhelming situation of just seeing people and as an individual every day. You see systematic problems and you don't know how to make them better. Your steps are: 1, look at that chip, see if anything strikes your fancy. There's people doing great work in your community right now, and you just don't know about it yet. You can look in your newspaper, you can look at your Healthy County website, just like before. And again, your next step is to schedule meetings with the public health director and beg them to tag you in. So whoever is doing the work in your community, there's usually someone who knows more about it than you. For us, it's usually Jennifer. Jennifer usually knows all the things that are going on in Klamath Falls public health wise and can just pull those little strings to plug this person in here and plug this person in here. And then lastly, if you're a large membership organization, maybe consider inviting a public health rep to your meetings, be on your board, something like that. It's big change, could be scary, I know, but this is just kind of off the cuff thinking. And then maybe think about exploring becoming public health Tinder, maybe making a statewide website. I don't know what that would look like. I just believe in the power and capability of member organizations to address the needs of their members. And if this is a need of the member, I think that we can try to get that going. Next slide, we'll just wave goodbye.
Yeah, thank you so much, everybody, for inviting us to this presentation. These are some beautiful pictures that Stewart has taken of our community. Please come and visit, talk to your public health directors, and yeah, we just thank you so much for all of the work that you're doing in our communities.
Yeah, you have our emails up there and our phone numbers. Give us a call.
Thank you so much, Dr. Decker and Director Little, for that incredible presentation. You touch on so many important areas and especially give us really great concrete ways that we all can get involved or be involved. I also want to point out that how much I appreciate you talking about the other kind of epidemic in Oregon, which is substance use disorder, and all of the public health and health sequelae from that particular issue that I feel like has somewhat gone to the wayside in our public eye because of the pandemic and some of the other things that we're facing. So I appreciate you touching on that and bringing up the importance of providers being able to care for that vulnerable population as well. So I appreciate your answering questions in the chat so readily, but I do believe we have some other questions to pose. And I will start with this one. Is your public health department planning to get involved around impacts of climate disruption, particularly in the setting of all of the wildfires that our whole state and much of California is experiencing right now?
Yeah, this is Jennifer, great question. And I briefly mentioned in the chat, but particularly in the Klamath Basin, but I know a lot of places around the state struggle with air quality. And so that's one of our biggest focuses. And certainly with climate change, air quality is going to be an extremely important issue. What we've done so far is we've been really well connected with our Economic Development Association and the Chamber of Commerce, because there are economic impacts of poor air quality, both for tourism reasons, but also for basically EPA restrictions that can be put on businesses. And you need to have a thriving economy to have having better health outcomes. So our business community does see that connection, which is really great. We've applied for a few grants through national organizations like Robert Wood Johnson to try to do more climate change work. We haven't been successful in that yet, but hopefully in the future we can do more of that work, particularly because it affects health equity in a major way, and we understand that.
This is Stewart. I just wanted to add two things to that comment. The first was that one thing Jennifer mentioned was a really big lesson for me, which is that our public health department had to apply for a grant to do some work on climate change, which means if they don't get that grant, it's really hard to do that work. So we mentioned earlier, one of the easy things that clinicians can do to help further public health is be available to help write grants or be a supporter for grants. It's just, I didn't really realize that there wasn't exclusively public funding for public health departments. You also had to write grants to do stuff. And then the second thing that I just always like to highlight when talking about climate change is that there's two ways to approach this. You can talk about the profound public health effects that will happen in the future from sea level rise and forced migrations. But sometimes in kind of the current partisan nature or partisan world that we live in, that kind of gets lost in the noise. So one way to focus on climate change is to talk about current pollution and current health effects, including asthma, lung disease, heart disease, and some of the interventions that you can push for to address current problems, current effects, will have those long-term effects that we're really looking for. So that's something that we can partner with public health departments as well, is to really get the word out about current downsides of pollution and ozone, et cetera.
Thank you. I also want to acknowledge just the interruption of your presentation with our sound issues and apologize for that. And I would like to give you both an opportunity to perhaps speak to some of that part of the presentation that was cut off. But before we do that, I really want to go back to something that Director Little said about partnering with the business community. And, you know, that was a question that came in the Q&A box. And I'm just curious if you have any specific examples of how the business community in your neck of the woods has partnered with, you know, you all as public health stewards, or if they haven't, or you don't have any specific examples, what you think might be ways to get our local business communities to really be invested in our public health initiatives.
Yeah, I'll take a stab at this first, and then Stuart, you can chime in. And one thing that I'll point out is that public health work doesn't just live within the public health department, right? I think we all understand that. And so a really great initiative that's happened in Klamath Falls is called Klamath Promise, which is a graduation and chronic absenteeism initiative. And the business community has been incredibly engaged. Like a local jewelry store owner sits on the board of that initiative, and they've done a lot around encouraging students to show up for school. They've literally knocked on doors. These business owners have knocked on kids' doors who have been absent for X amount of days and say, we really want you back in school, because they understand that larger concept of how education affects your health. On the public health side, more traditionally, like I said, we've partnered with the Economic Development Association and our tourism office, and working with them on just a variety of initiatives, whether it's research or, like I said, air quality, wood stove change outs, those kinds of things. And so I don't necessarily know what that looks like engaging businesses in a metropolitan area, but because we are rural, it's very easy to get connected and really get people involved, particularly in the business community.
So two things that I can add. One, Klamath Falls recently put in a protected bike lane. And part of the reason, or part of the way that was approved, was, of course, all the wonderful health impacts you get from encouraging biking, encouraging connectivity, encouraging just non-auto travel. But one of the ways it was sold to the business community is all the alternative, like the additional benefits for home value increases and increased foot traffic and bicycle traffic along main business thoroughfares. So it does highlight that a business case can be made to businesses for a lot of our public health interventions. As I mentioned in the presentation, I do believe that there is health in all policy, which just means that all policy can also, even things that don't necessarily seem to have a particularly big health impact, we can make a health case for them, but then also things that have a really obvious health impact probably have a business side to them too. The second part is that one thing we're working on right now is a smoke-free like health area. The hospital is kind of located a little bit north and east of downtown, and the goal is to create a 3-block or 4-block area in which it's a dedicated no smoking area. And to get those businesses, because there's a lot of businesses in that several block radius, to get those businesses involved, it's really just direct outreach. Our people, our CEO, our board of directors, our clinicians going to those businesses and asking them personally to participate. I think that very individual connection goes a long way. And then just smoke-free areas. One of the things I've been learning recently in tobacco research is that having a smoke-free workplace does more for decreasing smoking rates than, say, even tobacco taxes do. So really worth pushing for.
Thank you. Those are great examples, and I think whether it's rural communities or metropolitan communities, I think you've given us some really good ideas about how to partner with local business. Another question came in that not all clinicians, so MDs and PAs and nurse practitioners who are seeing patients have training in foundational public health concepts. And so the question is, with the Healthy Klamath Project, was there some workforce development or training available for clinician partners?
That is an excellent question and an excellent idea. No, we haven't done that. And gosh, I think we should just take that. We might steal your idea. Thank you, whoever gave that idea out. But there are a lot of great resources out there for individuals who do want to dabble in public health, maybe learn up on it. NACCHO, which is the National Association of County and City Health Officials, has a ton of really excellent information on there, 101, 202 kind of modules. ASTO, which is the Association of State and Territorial Health Officials, is another really great resource where people can just get some of the basics for that kind of work. And yeah, Stewart, anything else to add?
Honestly, so I'm doing my master's in public health courses right now. So I'm learning a lot of those foundational public health concepts. Also, I know that schools or medical schools currently are, at least my experience with current medical students, is that they're getting a lot more training going through medical school as we speak, which is great. But what I found is, even though I'm going through MPH classes, I am getting some of this foundational public health concepts. A lot of it is great in terms of me understanding what is going on, but I still find that my most productive moments come at the hands of someone like Jennifer saying, oh man, you know what we could really use somebody for? We could use somebody to do this, and kind of being steered or pointed in a direction. And I don't want to kind of diminish people's passions. Like, if you have an idea that no one is doing currently, then man, it would be really hard to do that without foundational public health concepts, to know where to start or how to start a project like that. But again, so often I feel like the times where I have felt the most impactful, it has been partnering with someone who is already doing something and them helping me along, figuring out in what way I can be the most impactful.
I think you both just exemplify the collaborative nature of public health projects. And it really is, it's really wonderful to even just hear you guys go back and forth about how, how modeling this partnership with folks who are the experts in public health, along with the clinicians who are seeing things day in and day out, is really, can really lead to success. So, so I appreciate that so much. I had a question about, you talk a little bit about how, in general, clinicians are looked at as people in the communities who are trustworthy, and who it's often a really great idea to lend their name and their profession to some of these public health works. I'm really curious about some of the concerns from communities of color and communities that have been disenfranchised and marginalized, and who have a distrust in the medical establishment in general. And I'm really curious about what you have found or have done, or what steps you've taken to help deal with that issue, and just make people feel more able to trust some of the initiatives and things that are coming out from your good work.
Yeah, one of the things that we've done particularly recently and through the COVID response, and I saw there was some comments and conversation in the chat box about this earlier, but the CBOs, the community-based organizations, have really come to the forefront and been our ally. I don't know necessarily what this looks like on the physician end, and Stewart, you can address this, but as far as carrying our messaging, the Healthy Klamath Coalition is full of CBOs. And so we've been able to really use them as our conduit and the bridge to those communities that they're serving, whether it's people with disabilities, people of color, people with linguistic or cultural differences. And so we do rely on people from those communities to be the messenger and to be that bridge. And certainly an initiative that we have moving forward is simply diversifying our workforce within public health in general. And so we've been working on what that can look like, and hopefully too the next presenter can help give even more education on that. But Stewart, how does it look from the physician end?
So there's a lot of ways to approach this. I think that one, with coronavirus, we have a large number of CBOs that are being tasked with contact tracing. And then what we have heard from those CBOs is that a lot of the times when they're doing contact tracing, they'll get a hold of somebody in whatever group that that CBO is specifically focusing on, who has questions about primary care, or connecting with physicians, or connecting with somebody who can give them healthcare that they don't necessarily know the answer to. So in that respect, the OAFP, the Oregon Academy of Family Physicians, is trying to help create some training to help teach those CBOs how to communicate about healthcare, about health professionals, to those people that are reaching with contact tracing. So that's option one, just like Jennifer mentioned, working specifically with CBOs who are addressing those kind of questions and health disparities among their, I guess, participant groups. The second way is we have this idea of really changing the baseline. So I think the example of that protected bike lane earlier was a good example of this, in which it is a change to the built environment that will affect people whether they know it is affecting them or not, whether they kind of are trusting the medical system, the individual clinicians, or not. So I think one other way of addressing some of our health disparities is really trying to dig down to like the really, really roots, where you don't necessarily have to even go into a clinic in order to receive the benefits from having new parks, or having safer walkways, or safer paths to school. But I think Jennifer's point, when it comes to specifically addressing underserved populations, it's working with people who already have trust capital with those underserved populations to develop that relationship first, and then from there kind of gaining exposure to those populations.
Thank you. So I wonder if we might offer you two a little bit of time to address some of what might have been missed in our small technical glitch, and I'll just open it up to you to comment.
Stewart, I feel like I've been starting everyone. Do you want to start?
It's great. So I think that one of the things that we missed, which I'll ask you to talk about, is just how the public health modernization is encased in Oregon statute and how that affects public health departments. But one of the things that we did miss was an example of our HPV work, the You Are the Key to cancer prevention project that we did. This was our first example of someone being a medical champion. Essentially, the public health department, as part of public health modernization, first started focusing on infectious diseases, and within Klamath and Jackson County, focused specifically on HPV vaccination rates. And what they decided they needed was a medical champion to connect with basically all the clinics in town. So I was approached primarily because I had, over the last several years, told the people in the public health department that I wanted to do things like this. And that had resulted in various letters to the editor, radio interviews, phone calls, et cetera. But this was the first big project that they said, oh, you know what, this would be perfect for a longitudinal approach for a clinician to do. And what that ended up looking like is going and doing train the trainer lectures or lunch lectures or trainings at every clinic in town about how to talk with patients and their families about the HPV vaccine. But I think the most important thing that came out of it was this kind of back and forth on systems thinking for how to create a system in each individual clinic that is specialized to that clinic that can help with increasing vaccination rates. And whether that is implementing new training for the rooming staff versus the administration staff versus the clinicians themselves. And then really one of the big swings was changing our electronic health record so that at every appointment, if someone was missing a vaccination, that was highlighted to them, leading to lots of new reports that you could run to call children and their families to tell them that they were missing this, that opened conversational doors. It really ended up, what was cool is that the people in the public health department didn't know that note templates and these electronic health record functionalities existed. And then once they had that input from someone using that record, they were able to develop these new targets that really did impact how we approach vaccination rates and improving vaccinations. So an example of how that partnership between a medical champion and a public health department, or in other situations, CBOs or other organizations can really flower because of your different backgrounds and perspectives.
Yeah, and just along with that, when someone like Dr. Decker is able to go and talk about the electronic health record changes, it does, again, carry more weight because they use that tool as opposed to public health saying, you need to implement this in your electronic health record. It's why would they listen to an outsider? So it just worked really well. But like Stewart mentioned before, and where it kind of cut out in the presentation, was that public health modernization was written into law in Oregon, and it wasn't funded as well as we would like, but I think that's the reality that everybody gets when they're asking for money from the government. And so those foundational programs and capabilities were looked at. The Coalition of Local Health Officials and Oregon Health Authority decided, where do we want to focus our efforts first? Because you can't just try to address everything all at once. So we focused on communicable disease, thank goodness, because then COVID hit and we were way more prepared. But moving forward, we are advocating for additional dollars because particularly after the pandemic, we've been seeing how incredibly underfunded public health is. And so hopefully modernization will continue to be funded at an adequate level so we can continue to really build a modernized public health system. And there is a toolkit online if somebody wants to read the whole modernization toolkit. It's up there and gives you a lot more background information on it.
Great. Thank you so much. I think we could probably continue this conversation for a really long time. There's lots of engagement in the chat, and I encourage you and Dr. Decker to perhaps answer some of the questions that have come in the Q&A box. But we do have to move on. Thank you again so much to the both of you for joining us today and for all of the incredible work that you all are doing. I personally am looking forward to reaching out to both of you with all kinds of ideas that are swirling in my mind, and I'm sure that many of our participants are as well. So thank you again for joining us today.
Thanks for having us.